Hello, good afternoon, everyone. Welcome to the third and the final day of the Uncover conference. We have about 100 participants registered for the conference today, as was the case yesterday and the day before. The theme for today's conference is transmission and policy. Next slide, please. So before we start the conference, a few housekeeping issues. This conference is being recorded and live streamed. Also to note that if you have any questions, and I'm sure that you will have a lot of questions, please do put them in your Q&A boxes. Remember Q&A and not the chat box. If you don't have a question, or if you wanted to, if you had a similar question, then please go ahead and vote on the questions. Again, the most popular questions would be put to our speakers, and I hope we have a good conference today as we've had the last couple of days. These conferences are being recorded, and the recordings will be made available on the Uncover website. So with that, I'll start today's conference. Next slide, please. So I'll tell you a bit about the Uncover conference. So the origins of Uncover. Uncover is about 6 months old, and we came together as an interdisciplinary volunteer workforce of staff, students, alumni, and even emeriti within the Usher Institute and within the broader University of Edinburgh to do rapid reviews of evidence for primarily the Scottish Government and for SAGE. We developed a rapid reviews methodology, and until now we've done about 20 rapid evidence reviews, and more laterally now we are starting to do systematic reviews. Apart from this, we established a register of reviews, and within this sort of register of reviews, more than 1,400 reviews, rapid reviews or systematic reviews on COVID-19 have been listed. And this is an incredibly handy resource for anyone who wants to find the latest evidence summaries on any COVID-19 related topic, or if you were going to start your own review. We have a website, and within the website, we make all the rapid review resources available to researchers around the world, and that's widely accessed, both our reviews as well as our register. And we have external link with the WHO, with other evidence review groups like the COVID-End, DELVE, the MRC and the Cochrane, South Africa, and also with the ISARIC. The funding for this was received from the Wellcome Trust ISSF3 and the DDI initiatives. And at the bottom of the screen, you'll see the link to the website for Uncover. Next slide, please. So within this Uncover, we've got about 31 student volunteers, and they are a diverse group. They include PhD students, Masters of Public Health MPH students, MBCHP students, and indeed students from other disciplines like physics and engineering. In fact, you would have heard from one of the experts from the science and engineering yesterday, Ignazio, who gave the keynote address. We've also been able to, through this Uncover initiative, carve out 4 student dissertation projects for our MPH students this year. The students have found it incredibly useful, and they've all enjoyed working on Uncover, as have we. And we have weekly workshops, some on running literature reviews, others on methodology and career development. And we also have promoted student-to-student video from the Uncover students to the new students who are coming to the University of Edinburgh starting this year, and how they can keep themselves safe and the others safe and act responsibly. And the final product of this Uncover, apart from the reviews and the registers and these videos, is this conference itself. Next slide, please. So this slide shows the Uncover team, and this includes the project leadership and others who have been working. And again, I'd like to thank all the students who put in an incredible amount of effort to make Uncover a success. Next slide, please. So as we've seen on the previous days, we start with a keynote and then we move on to some talks on individual topics. And I'll talk about the individual topics later when we start the presentations. But the keynote today is by Professor Aziz Sheikh, who needs no introduction. And Aziz is the Professor of Primary Care, Research and Development and also the Director of the Usher Institute. He is also the Dean of Data at the University of Edinburgh. He is a honorary consultant in pediatric allergy and at the Royal Hospital for Sick Children, and he is the director of several initiatives. For example, the Asthma UK Centre for Applied Research, the NIHR Global Respiratory Health Unit, Respire, and the HDR UK Breathe Hub. And he is also the co-director of the NHS Digital Academy. Aziz has had substantial academic and health policy interests in leveraging the potential of health information technology and data science to transform the delivery of healthcare and improve population health. And this has led him to work with numerous governments and the WHO and the World Bank. He's a member of the Scottish Government's COVID-19 CMO Advisory Group and the UK COVID-19 College of Experts. He's been honored with fellowships and from the 9 learned societies. He was awarded an OBE for services to medicine and healthcare in 2014, and recent awards include the American Public Health Association's Donovadian Award and the University of Edinburgh's Principal Medal for Exceptional Services. He is also inducted into the highlycited.com. I'd like to now welcome Aziz. Over to you, Aziz.
Thanks very much indeed, Harish. It's really great to join you all today. So first of all, I think just an enormous thanks to the entire Uncover team, the leadership team, all those who've been contributing and supporting these reviews. I think you've done an absolutely outstanding job at a time of immense national and international need, and that work is ongoing. So just, again, enormous thanks to you all really for that. I'd also like to thank our Usher comms team. I know they've been supporting this important event and more generally for all the response help that they're providing with the COVID response. So what I wanted to do, Harish and colleagues, is just very briefly talk about how we can actually support the needs of policymakers in the time of the pandemic, a real public health emergency. And I've only got one slide, and I'll be relatively brief. I'm going to speak for about 10 minutes or so, which I hope will leave time for questions and discussion. So I want to share 10 key lessons, and if you can click through to the next slide, please. This is my take on things, so people may disagree, people may have other lessons, there may be dimensions to this that I'm missing, but let me in any case, share with you my thoughts, and these have largely been accrued for, having working with policymakers over a decade, and then having done this Harkness Health Policy Fellowship in the US, where there's a lot of interface with international governments and decision makers, and then more recently in the context of a pandemic. So I think the first thing we as, and I'm speaking particularly for us as academics, we need to try and understand is what are the challenges that are being faced by decision makers. So we can try and wear their shoes. I think that would be incredibly helpful. Typically, as academics, we want to answer very focused questions. So we may want to answer a question about whether surgical face masks are important, for example, in reducing transmission of SARS-CoV-2. So that would be a traditional kind of systematic review, evidence synthesis. But I think if you're sitting there as a policymaker, you're interested in a much broader question or series of questions. So, for example, it's not around just surgical face masks, but it's around, well, do N95 masks add additional value? What about if we move to home-based face coverings? So these are self-made. Do they offer similar or broadly similar levels of protection? What's the likely acceptability of these masks going to be? Are people going to wear them? What are the kind of social order implications? And so I think if you're sitting there as a decision maker, particularly at this kind of time, what we need to do is try and sort of envision that position and think about trying to produce and identify and synthesize evidence in the round that might be able to help that decision-making process. The second question, or the second point I wanted to make was around developing and maintaining trust. Now, clearly, trust takes a long time to develop, and I think in the Usher we're in the very privileged position of having a lot of trustworthy relationships already with decision makers, so it's relatively easy to build on those. But I think then maintaining that trust is really important, and I think it's also thinking about the layers of trust that are needed. So in the context of this pandemic, public health emergencies, quite often what we're dealing primarily with civil servants. They're highly skilled, but this is a group that, historically we've had no sort of relationship with. So it's thinking about trust at that level, but then also with the more senior decision makers. And much of what I go on to say will be related to this. It's in a very similar vein, because all of these things really matter if we're trying to think about trust. But what there should be is, I think, if we're doing this, in the right way, there shouldn't be any surprises. So it shouldn't be that things are being said in the media, for example, or sort of social media pronouncements that take policymakers by surprise, particularly if we're interfacing with them. That should have been raised with them right up front. And so, giving them advanced sight of material is not with a view to veto, but so that they're aware and they can begin to frame their response is, I think, really important. So it's not being in their pocket, but I think working with them in responsible ways. Now, the third point I wanted to mention was trying to develop collaborative ways of working. And I think you're doing this in the Uncover group really well. More generally in the Usher Institute, we're trying to move in this direction. So what we want is to be engaging with the very best minds, the real expertise wherever that exists in the world, and engaging proactively in sort of responsible ways. And I think if we do that, not only do we bring the very best minds to bear on the problem at hand, but I think this also feeds into this trust agenda, because these are then individuals whose expertise, disciplinary background, sometimes their names are recognized, and I think that is always very helpful. So the third point really I wanted to make was really thinking about open, collaborative team science ways of working. So this is a work in progress, and I think we are getting progressively better at this. The fourth point is around really trying to understand and respect decision-making timelines. So, for example, if we're reporting into SAGE, we need to know when SAGE is meeting. So SAGE is meeting today, for example. When the Scottish Government COVID Advisory Group meetings are happening, that group is next meeting the coming Monday, for example. And so, the issue here is that there are times allocated for discussions. So at the moment, SAGE is having a discussion around ethnicity again. And if we're not mindful of those discussions, we miss the boat. And really, typically, there isn't the time to. So we can then produce our reviews. But if we've missed that boat, then the time to influence has really passed, because that issue may not be revisited again, or it may not be revisited again for several weeks. And hence, just some apologies, because a lot of the requests for reviews are coming from me, and sometimes I know they're coming in on a Sunday morning because the timeline, or there's been a decision to kind of have a discussion 3 days from now. And so, these are unusual times, but I'm just very, very grateful that people are being responsive, really, and recognizing that we have windows of opportunity, as John Kingdom describes to influence policy. And here, these are very sort of small or short windows, but I think colleagues have been receptive. I'm very grateful for that. I think, again, in relation to trust, and I think we're very good at this in terms of doing this academically, but being completely upfront about conflicts of interest, potential biases in what we're doing is, I think, really important. It feeds into the trust agenda. It's the right thing to be doing. I think sometimes if we are very conflicted, stepping aside from a particular piece of work is the right thing to do, or stepping outside of a discussion. And I think, again, that is really valued by decision makers. They want to know that we're kind of responsible. If we've got sort of public advocacy positions, it could be that it's time that we just kind of keep quiet on a particular issue and let others debate and decide on those issues. So I think that again is really important, and conflicts of interest will change, and keeping colleagues updated on that is, I think, useful. The sixth point I wanted to make was around trying to contextualize findings. And so, as I think you've found, is that there are a number of groups around the world that are undertaking rapid evidence syntheses. I think that's welcome. Really, wherever possible, we need to be trying to avoid duplication of effort. We need to be doing things that are complementary. But if there are other reviews that have been done, so for example, face masks or face coverings, groups around the world have looked at this. And so as we synthesize what we've done, if we can put this in context for decision makers, I think that can be very helpful, even if some of these other reviews, are coming to different conclusions. I think just being open, transparent, responsible, mature around this, I think, is incredibly helpful. Presenting findings in ways that really are accessible to decision makers, I think is important. And with the Uncover reviews, I know what we're doing is providing a bottom line right up front. It's not the way we write academic papers, but some of these SAGE meetings, they're getting 30 substantive papers to review. Patrick Vallance and Chris Whitty have got other things to do, in between all of this. So, I think as a rule of thumb, if we envision that there's probably no more than 1 minute per paper that people will have to look at, that probably, will help us. So with the bottom line, the executive summary, ideally bulleted, and then for people who are interested and have got the time, and sometimes these are the civil servants, more details provided sort of beyond that front page. But getting this right is important, because otherwise there's no way that people will be able to engage with this, particularly in pandemic contexts. Point 8 is, what I said, a lot of our interfaces with the civil servants, and they play an incredibly valuable role. I think if we can try and get what we're producing right to the very top, doing it, appropriately, transparently, is very helpful. So, I know with the reviews that, you guys have been producing, that I've been involved in, shepherding the other end. Those have gone directly to the leadership of SAGE, for example. They've gone directly to the leadership of the CMO advisory group. And many of these reviews, because they have been of such high quality and they've been so well received, they've been passed on with permission to other government departments. So, for example, the schools working group, or the ethnicity working group, or groups looking at outdoor transmission, or to SPI-M, etc. And I think that's really a testament to what you guys have been doing. Point 9 is to inform policy making. That's what we're trying to do here. If what our work is accessed, is accessible, if it's read and understood, then I think our job is done, really. Our job is not really so much around advocacy. We can do that, but that needs a kind of a different approach, and we need to be very deliberate if we're moving in that direction. We shouldn't be mixing these two roles. Policymakers are grappling with this issue, but they're also grappling with a variety of other issues. So, for example, issues to do with indoor-outdoor transmission, really important, but clearly issues to do with education are being grappled with there, mental health issues that people are grappling with as they're working from home, the economy is obviously, going to be already a very, very substantive issue. I think we've had a kind of a 1/3 shrinkage in the economy of Scotland. That has major implications. So what we're producing has a bearing. It's important, but there are other issues that are being considered, and that's only reasonable. So I think we should be trying to inform policy making. If we're going to move to advocacy, be absolutely explicit around that. There's no harm in doing that, but we shouldn't be mixing these approaches, is my kind of suggestion. And then the last thing, I think you know that now. So with the Scottish Government CMO Advisory Group, reports are being published. So they're being put onto the Scottish Government website. SAGE reports are being published. So everything that we produce that's going into these government bodies, we should now anticipate this will be going out into the public domain. Media will be reading this. Public will have access to this. So I think marking this, as we do, that these have been produced very rapidly. These are our first take. If we're envisioning living reviews, as I think are really important with some subjects, less important with other subjects, then making that clear, that's important. And then, of course, what we should always be doing, we are academics at heart, is, if you produce a review in 3 days, that's going to be a very different sort of proposition from one that's produced, over several months. But we should be contributing to that scientific agenda by trying to put our work into the peer-reviewed domain, really. So I think if we can translate in that sense as well, that is incredibly valuable, because these are then journals of record. These will be read for decades, if not centuries to come. That's not the same with SAGE papers, I don't think. So I hope that's been of some help. These are kind of, and it was helpful for me trying to sort of put down these bullets, but very happy, Harish, to take any comments, questions, suggestions, other thoughts. I don't have the final word on this by any stretch, so if people have got other lessons they want to share, that would also be very valuable. Thanks very much indeed, and thanks again for all that you're doing. Thank you.
Thank you, Aziz, for the excellent talk. I'll start off with a question that came to my mind, and this relates to your statement regarding interacting with media or social media. So, what's your experience of advisors to governments working with or using media and social media to promote their own views, if those views are not consistent with what is the government policy? Do the governments view this as something that they don't like, and is there a problem with that? And then what do you do as an expert if your own, the opinion that you give and majority of the other experts give is not something that translates into policy, and you find that that has important implications in public health?
So thanks, Harish. A great series of questions that I think all of us in government advisory roles will have to grapple with at some point or another. People will come to different positions, and I think we need to sort of respect that. But let me tell you where in the position I've come to, really. So, with the government advisory roles that I'm doing, in this context, I had one episode where I was going onto the media trying to talk about something else, some of the research work I was involved in. I made that absolutely clear as I sort of went into that discussion with the media. However, they began by opening saying, well, Aziz Sheikh is government advisor to, X, Y, and Z committee, so they sort of, pigeonholed me directly in that respect right from the outset. And then much of the interview was about me trying to critique what government is doing publicly rather than what we had agreed. So, I think you can end up in very compromised positions. As a result, I've taken the decision that whilst I'm in these roles, I will not be doing any more media-facing work directly. That's a decision I've come to, as far as possible. But others have come to different decisions, and I think we just need to respect those, and they may have other reasons for doing that. In relation to, it may be that we give advice to government and government chooses to do something else. Actually, on most things, my experience is that the Scottish Government have been incredibly receptive to the advice that they're getting, but they haven't followed, everything that we've been advised. I think it would be rather bizarre if they did follow everything, because scientific advice, as I said, is only one bit of the equation. I think what we then have the choice is then we can sort of take that on the chin. We recognise that there are other sort of, lines of evidence or information or things that they're having to grapple with. Recognise that, that it's not followed at this moment in time, but this has got a long burn. We're sort of 10% through this pandemic at the moment, so it may be that that advice is picked up on in due course. It may be that it's never picked up on, and then it can, if one feels very strongly about this, it could be that we kind of step out of that government role, resign from that position, and then, of course, then we're free agents. We can sort of talk about things publicly as we think fit. So I think there are different responses here. I told you my position, but I know there are other positions. Harish, you're muted.
Thank you, Aziz. I think I found that helpful, and a lot of other people will find that helpful, because people may find themselves in sort of similar positions in future. Another question that we have is, what do you see as the future for rapid reviews? So at the start of the pandemic, there was a rapid need for evidence, and therefore people started with these rapid reviews. But that was sort of the sprint phase, and now we are into some kind of a marathon phase where what people want and people are thinking of are these sort of more systematic reviews and living systematic reviews. So do you still see the need for rapid reviews?
Yeah, so I think, considering the kind of enormous global effort that there has been, and it's been really heartening to see that. I think there has been, a number of these rapid reviews have been instigated all over the place. So I think we would need to think quite carefully before instigating new reviews, rapid reviews. But I think in terms of where these reviews have started, it's being very deliberate around which ones we think need to be turned into living reviews. So let's, for example, think about transmission. So we know, in part because of the work that's been done by Uncover, that outdoor spaces are much safer than indoor spaces. But on the indoor spaces, as there is this drive to try and get sort of people to return back to work, in part to kind of stimulate in the cities and sort of commercial activity there. A question that's come up in government circles is, what's the role, for example, of HEPA filters? Are they protective? What's the role of air conditioning systems? So those kind of issues, if there's a review already started, these could potentially be absorbed into a living review. So I think that probably is where the focus of activity now needs to be. And then I think wherever possible, sort of converting what we've done and putting those into sort of systematic reviews. The ethnicity one is also, I think, really important as a living review, because, at the moment, nearly all of the work has been on the first order effects of COVID, but what about the second and third order effects, which we think are probably likely to disproportionately affect minority ethnic groups. The second order as a result of the health and social care system being massively disrupted. It still is. Third order is as a result of the economic effects translating into health outcomes. So that, again, could be an example of something that's a living review. I don't think face coverings is one that should be a living review, and a policy decision has been taken on that issue, for example.
Thank you, Aziz. I understand that you need to leave now, and it was a privilege and pleasure to have you with us today and to listen to you and to gain insights from you. Thank you, and I wish you all the best for the rest of your day.
Thanks very much, Harish. Thanks, everybody, colleagues. Thank you. Bye.
Next slide, please. So we now move to the next two presentations. So we are going to have two presentations now. The first presentation is looking at risk factors for poor outcomes in hospitalized COVID-19 patients. And this, again, this work came out of one of the suggestions from Aziz in the initial days, but this is moved from a rapid review to a more substantive, systematic reviews. And a team of researchers, 7 researchers, including students, have been working on this. And today we'll have Izzy DeGuero, who is a final year MBCHB student in Edinburgh, and Delani Ashcroft, who is a medical doctor and MPH, part-time MPH student at the Usher Institute, present on this. Over to you, Izzy and Delani.
Thank you, Harish. My name's Izzy. I'm a medical student, and as Harish said, I'm here with Delani, and we're going to give a brief talk on a review we've been a part of, and this is on risk factors for poor outcomes amongst hospitalized patients with COVID-19 disease. Next slide, please. So I'd first just like to acknowledge everyone who's been a part of this project. It's been a really multidisciplinary team. We've had lots of different students, research fellows, and people involved from all different kinds of jobs, and that's been great. Next slide, please. So just a brief outline of the talk. I'm going to talk a bit about the significance of this research question and some of the evidence that's currently available. And then Delani's going to give us a bit of a talk about the review itself. Unfortunately, we don't have any data to present today, so we're going to focus on the methods of the review and some of the challenges that have come up in a research question of this size. Next question, next slide, please. So why is it important to identify vulnerable groups? Well, in any pandemic of emerging infectious disease, it's important to identify populations who are going to be at risk for severe outcomes in hospital. And this is for multiple public health purposes. So first of all, it allows for anticipatory care planning. If we can identify individuals who are going to progress to severe disease, it allows us to take actions such as preparation of the anaesthetic team for ventilation and intubation, or facilitating bed spaces in the ICU unit. This kind of knowledge could also be used to prioritize access to healthcare facilities in the primary care setting and for promotion of behavior modification. And the key example of that would be shielding advice, which is currently implicating a really significant proportion of the population. And this figure here shows the numbers as of August 2020 for people who were shielding in England. And you can see that's over 2 million, so it's implicating a lot of people. Looking forward to the future, we could use this knowledge to stratify vaccination policies through a system similar to that which currently exists for influenza. And we might also be able to do some mathematical modelling to project the likely impact this pandemic is going to have over time for high-risk groups. So evidently, there are multiple uses for identifying patients who are going to have poor outcomes in hospitalized settings. Next slide, please. So what do we know already? Well, we know that age and male sex are quite well documented factors. And Aziz and his colleagues have already produced a really comprehensive early review, and they looked at risk factors for overall disease severity and death. And this included non-hospitalized patients, and so was distinct from our work, and had evidence published up until the end of April of this year. Amongst their findings, they established that age was the only risk factor with a really consistent body of evidence behind it at that time to show that it increased risk of severe outcome and death. We also know that unlike the respiratory coronaviruses, which are associated with the common cold, the SARS coronavirus 2 generates a hyperimmune response or cytokine storm, which stresses multiple other organs, particularly those which have lots of microvasculature, such as the kidneys, lungs, and heart. And patient groups who have comorbidities of these systems are particularly at risk. What do we need to know a bit more about? Well, We know that there is a role for ethnicity and deprivation, and we've already heard from Gwinnetta Curry about some of the great work she's been doing to draw a focus to ethnicity in particular. And so we wanted to include ethnicity and deprivation in our research question. There's also ongoing interest into the role of the antihypertensive medications, ARBs and ACE inhibitors. And so we chose to include that in our research question as well. Next slide, please. This is just one figure I wanted to draw a particular attention to. It's from the study which was published in May, and it gives data for 20,000 UK admissions up until the end of April. And it shows risk of death for hospitalized patients by different risk factors. And you can see that age most strongly defines survival, and also that women are 20% less likely to die than the standard risk of death in hospital, but also that there are multiple other comorbidities which can significantly implicate risk of death in hospitalized settings. And this was a really valuable early study. Next slide, please. So what does this project add? Well, we know that there's a very large body of evidence that has rapidly become available, but there's been multiple challenges in synthesizing this data. So, for example, early outcomes of people with critical illness have been described in hospitalized settings, but they often include substantial incomplete follow-up. There's a lack of consistent use of case definitions and lack of consistent case identification methods. And what we wanted to do was to undertake a systematic review and quality appraisal of the available literature and just establish a global picture of the evidence on poor outcomes amongst hospitalized patients. And I've included the Prospero ID and link here with some more details about the specifics of our research question and methods. And I'll now hand over to Thulani, who's going to talk a bit about the review itself and the progress so far. So next slide, please.
Thank you, Izzy. So I'll be presenting the methods we used for the systematic review, starting with the search strategy. This was conducted at the end of May using PubMed, medRxiv, and the WHO COVID-19 database. The concepts for the title and abstract search were defined as the population, the outcome, and study designs. The population concept was terms for COVID-19, such as novel coronavirus and SARS-CoV. The outcomes were associated to the severity of the illness requiring hospital admission, which included ICU and death. There were no restrictions on the type of study as long as it provided the data we required. Next slide, please. The following inclusion criteria were used for the title and abstract and the full text screen. We were specifically interested in hospitalized patients with details on demographic and or clinical risk factors associated with 5 poor outcome measures. These were requiring high flow oxygen, ICU admission, non-invasive ventilation, mechanical ventilation, and in-hospital death. As many studies had only small numbers, papers often grouped outcome into severe or critical. These were included if their definitions contained one of our specific primary outcome measures. We chose papers which identified cases by laboratory diagnosis. The majority of these specified PCR. Some earlier papers used terms such as nucleic acid test and molecular testing. Next slide, please. With regards to exclusions, we didn't include any non-English papers. As the systematic review was focused on hospitalized patients, we excluded studies where it was unclear if cases had been hospitalized prior to the outcome, and when the case definition was based on symptoms or suspected cases. Other exclusions were if no numerical data was available, such as reviews and editorials, where we could not extract data from placebo-controlled arms of randomized controlled trials, and where there was no comparison group. This led to exclusion of pregnancy data, as none of the primary studies had a comparison group. By examining the location, author, and study period, we were able to detect papers which used the same study population. These papers were further examined with longer follow-up period used to select the paper for review. Lastly, many systematic reviews were identified by the search. Though we didn't use this data in our review, we undertook a separate analysis of these papers, which I'm going to discuss later. Next slide, please. The data was extracted on a broad range of variables associated with our primary outcome measures: high flow oxygen, non-invasive ventilation, mechanical ventilation, ICU admission, and death. So these variables included demographics, age, sex, and ethnicity, any type of comorbidity, and medications such as ACE inhibitors and angiotensin receptor antagonists. The information was collected as counts, odds ratios, and hazards ratios. Next slide, please. This is the Prisma diagram of the systematic review. The search produced 3,113 articles. After removal of duplicates using EndNote, 2,643 titles and abstracts were screened. Our team had 6 reviewers who worked in pairs to independently review the title and abstracts. Any disagreements were resolved jointly. This process identified 842 papers. A different pair of reviewers worked in a similar fashion on the full text screen of papers. Queries regarding inclusion were discussed either between reviewers or, if unclear, with the project lead. After exclusions previously mentioned, 219 papers were highlighted as suitable for data extraction. Next slide, please. So we wanted to talk about some of the challenges with the project. This was an evolving project. When we started in May, we planned a rapid review and had a general idea of the research question, which became more refined during the process of reviewing the literature. There were a large number of papers to assess over a few months, and new papers were going into preprint as we were conducting the systematic review. We realized how diverse the articles were and piloted several appraisal tools for quality assessment of the papers. After trying the CASP tool and the Newcastle Ottawa, we chose Joanna Briggs Institute Critical Appraisal Tool as the most appropriate. In particular, they had separate tools for case series, case control studies, and cohorts. Reviewers independently assessed the quality of paper. Common issues in some of the lower quality papers were no assessment of confounding factors, insufficient follow-up period, and incomplete follow-up. By using only 3 databases and excluding non-English papers, we limited our data, and so may have missed some associations. In particular, early Chinese and South American studies may not have been incorporated into the review. We were not able to assess pregnancy as we initially planned due to the lack of comparison group. Many studies publish laboratory data, such as neutrophil lymphocyte ratio and D-dimer levels. However, we decided we had insufficient time to extract this data. There were 51 systematic reviews found by the full text screen. Unfortunately, due to lack of resources and time constraints, we were unable to extract the primary studies. In fact, some systematic reviews didn't clearly publish which papers they had used for their data. Instead, we summarized the evidence in terms of aims, main findings, limitations, and quality. When comparing them with our review, we found ours was more recent, covered a broad geographical area with studies from China, USA, Europe, and the Middle East. Data was extracted for a wide range of comorbidities and was specific for hospitalized patients with distinct primary outcome measures. Next slide, please. As previously mentioned, this is a work in progress. Data is currently being cleaned and prepared for analysis. The plan is to undertake a meta-analysis for each of the 24 risk factors. In addition to demographic characteristics, we have information on many clinical conditions which are shown by this table. Furthermore, WHO SAGE has expressed an interest in the results of our analysis to aid their global guidelines. Next slide, please. Thank you for listening. Izzy and I would be happy to take any questions.
So thank you, Izzy and Talani. That was an excellent talk. And we have questions. So the first question is, why did you restrict your patient group to only hospitalized patients? Do you think that was a pragmatic decision? And what do you anticipate is the risk of bias, given that there is a significant proportion of deaths that occur outside of hospitals?
So yeah, that's a good question. I think you're right. You answered it. It was a pragmatic decision, partly because there was a lot of data available, and we wanted to try and there is bias because earlier on in the pandemic, different patients would have been hospitalized rather than later on, and different countries may have hospitalized different types of patients. But it was really a pragmatic decision because of the number of papers that we had and the time that we had to analyze them. Izzy, do you have any other points that you wanted to add?
Yeah, I would agree with you, Zalani, and perhaps add that there's kind of a significant danger in equating poor outcomes in hospital to meaning high-risk groups. And that's something we would have to carefully consider when applying this data, because clearly it doesn't include community settings and deaths in settings such as care homes. So it would limit application of this data to hospitalized settings. Out with hospital, it could still be used, for example, for vaccination policy, but it would need to be viewed alongside community data. It's more of an overarching picture.
Thank you both. The next question relates to long COVID. So there are probably as much as 60,000 patients in the UK who may be having long COVID symptoms, and that could last anything between 3 to 6 months. Do you think that any of the data that you've included could be used as an additional outcome for the long COVID analysis?
I think that's a tricky one because a lot of the long COVID patients may not be admitted to hospital, and they'll be mainly managed in primary care. So, and we don't know what the long-term outcomes are for people that have needed invasive ventilation or mechanical ventilation in hospital. I think most of the data would be primary care for long COVID. So yeah, it's difficult to see how our bit of work would help in that situation. Izzy?
Yeah, I would agree with that. It would be difficult to capture such patients in a study like this, unfortunately.
So that's all as regards to questions. So thank you both for the excellent talk, and we'll move on now to the next talk. Next slide, please. So the next talk today is looking at the temporal association of introducing and lifting non-pharmaceutical interventions with the time-varying reproduction number of SARS-CoV-2. Now, as you're all aware, I think even the man on the street now has heard R millions of times and understands R. So to the extent that this is the number, this is the one magic number that will indicate whether the disease is on an uptick or is decreasing. So obviously there's a lot of discussion around R, and again the work came about with the initial request from the SAGE to understand the role of R in introducing lockdowns and lifting of these lockdowns. But Leo has then moved on now to do a more substantive analysis, looking at the data from different countries. And the presenter today is Yu Li, who is a research fellow with the Respiratory Viral Epidemiology Group at the Center for Global Health. Leo came to Edinburgh 4 years back on a scholarship from the China Scholarship Council and has now stayed on to do some postdoctoral work with the Respiratory Viral Epidemiology Group, and he has an interest in mathematical modeling. Over to you, Leo.
Okay, Thank you, Harish. Good afternoon, everyone. So today I will present the work on the temporal association between the non-pharmaceutical interventions and the time-varying reproduction number R. Next slide, please. So before I start, I'd like to acknowledge the following persons who work on the review on different stages, and especially I'd like to thank all the three students who work on the literature search, Durga, Rima, and Alice. Next slide, please. So I will brief what's known about this topic, and then move on the method and what this study adds to the existing knowledge pool. And lastly, I will briefly go over what to do next for future work. Next slide, please. Okay, so just a bit of the background. So we all know that earlier this year, non-pharmaceutical interventions, or NPIs, which could reduce SARS-CoV-2 transmission, were introduced by many countries around the world. And since May 2020, a number of countries started to lift some of these NPIs, and some of these countries have witnessed a second surge in COVID-19 cases. So it's really important to understand the impact of introducing and lifting these NPIs on the transmission of the virus. Next slide, please. So as we kind of are more familiar either from media or academic meetings, we know that the time-varying reproduction number, or R or RT, is defined as the expected number of secondary cases arising from a primary case infected at time T. So R or RT measures the instantaneous transmissibility, and R of below 1 means that the epidemics will die out, and then R over 1 means that the epidemics will sustain. So therefore, R can be useful for assessing whether the current interventions are effective, or we need additional interventions to be in place. We found from earlier studies from China, South Korea, Singapore, and Europe that the major NPIs could reduce R substantially to near or below 1. However, little was reported regarding the effects on R following the relaxation of these NPIs. So that's the starting point of our review. Next slide, please. So this initially this was a review on the NPIs of different countries, and look at the association of NPIs and R number. But then there was a group from Oxford which systematically collected the NPI status. So now this review has been developed into a secondary data analysis that used the data from the data on the NPI from the Oxford group, and also the data on R. So briefly, the study aims to understand the effect of introducing and lifting NPIs on R from a broad perspective across different countries all over the world. And we aim to assess the individual effects of the following NPIs for both introducing and lifting. And we also aim to look at if the effects of introducing or lifting NPIs are immediate or delayed, and if being delayed, then by how long. Next slide, please. So as I mentioned, we used two different data sets. One data set on R from the London School of Hygiene and Tropical Medicine, and the other one from the Oxford group. Combining these two data sets, we come to a data set of 131 countries with both the daily estimate of R and the daily status of 8 NPIs. And we developed a model which could estimate the effects of introducing and lifting MPIs from day 1 to day 28 following the introduction or the relaxation. And especially we in the model we used the R ratio to measure the change in the transmission in the transmission of SARS-CoV-2, which is the ratio of R on day I over the R number on day 0, which is the day right before an MPI was introduced or lifted. Next slide, please. So here, this is a slide showing the frequency and the temporal sequence of MPIs across different countries. So we can see that requirements to stay at home is the most common MPIs introduced and lifted by different countries, and often than not, it was introduced or lifted simultaneously with the internal movement limits. And international travel limits tend to be introduced and lifted alone, not with other MPIs. And with regard to temporal sequence, the school closure was often the first MPI to be introduced by countries, and the requirements to stay at home was often the last one. And for relaxation, the public transport was the first one that were reopened by countries, and the public events were the last one that were allowed by countries. Next slide, please. So this slide is the main results of this study. So we look at the individual MPI level effects on the R. So we look at the introduction of the MPI, which is shown here in blue, and also the relaxation of the MPI, which is shown as red. So we can see that school closure, workplace closure, public events ban, requirements to stay at home, and internal movement limits are all associated with a reduction in R of 7% to 24% on day 28 following the introduction. And for the relaxation of MPIs, reopening school, lifting ban on public events, lifting ban on social gatherings of more than 10 persons, and lifting internal movement limits are associated with an increase in R of 11 to 25% on day 28 following the relaxation. Next slide, please. And furthermore, we wanted to look at whether the effects were immediate or not. So as you saw from the previous slide, the effects were not immediate. So to quantify this, we use a threshold of 60% of the maximum effect, and we look at how long or the time lapse in terms of days in order to observe a 60% of the maximum effect following the relaxation or the introduction of NPIs. So basically, we found that it generally took 8 days following the introduction to see a decrease in R, and it took even longer, which is 17 days following the relaxation of NPIs in order to see an increase in R. So one of the possible explanations for that is something we call behavioral inertia. So people tend to behave, not immediately following the change in the policies. So in order to validate that, we also conducted additional analysis using Google mobility data. Next slide, please. So in this additional analysis, we wanted to know whether this delay or the behavioral inertia were found if we use the mobility data in replace of R. So, and quite interestingly, we had the similar findings here. So taking the workplace closure as an example, we look at the effect of workplace closure on the total number of visits to workplace from the Google mobility data. And we found that the delay was almost was very similar to the delay we found if we using R. And the similar findings could be seen here for stay at home. And so again, we found the results were very similar for both the introduction of the MPIs or the relaxation. Next slide, please. So to summarize, we found that the number of MPIs are associated with a reduction in R of 7 to 24% on day 28 following the introduction. And also several MPIs, including the reopening school and allowing public gatherings, are associated with an increase in R of 11 to 25% on day 28. And we know that the effects of MPIs are not immediate, and it takes 8 days to observe 60% of the maximum reduction in R following the introduction of various MPIs, and even longer in order to observe the 60% of the maximum increase in R following the relaxation. And all of these findings above can provide additional evidence that can inform policymakers' decisions on the timing of introducing and lifting different MPIs, and also more importantly, on when to expect to see the effects of introducing or lifting these MPIs. Next slide, please. So on some of the future work, so basically this study look at the association between MPIs and the transmission, and also as a validation analysis, look at the association between MPIs and the behavior. So for future studies, we could also look at the association between behavior and transmission, and or behaviors and cases, number of cases and deaths, as an tool for early warning of potential epidemics or outbreaks. For example, on seeing the increasing activity of populations, and then we could give early warnings to the public that there will be likely to be an increase in the number of cases in the coming weeks or coming few days. So next slide, please. So that is all of my presentation. Thank you for your attention.
So thank you, Leo, once again for the excellent talk that you've given today. And just for everyone's interest, this paper is under active consideration by the Lancet Infectious Diseases. It has gone through one round of reviews by peer reviewers, and we've responded to comments, and is now back with the reviewers, and we hope to receive a decision on this manuscript soon. I'll encourage everyone to please post their questions in the Q&A box and not in the chat box. We are seeing some questions being put on the chat box. That's not really being monitored. So, Leo, one question that has come through is, did you look at the different mitigation measures when the restrictions of specific NPIs were lifted? For example, use of face masks in shops or public transport, or reduced mixing, or use of these ear bubbles in schools. Is it possible that there may be data available on these?
Right. Thank you, Evie, for the question. It's a very important question that is related to the mitigation strategies that country are currently considering. So in short, we do not, unfortunately, we do not have the level of details in our data that can look at these specific aspects. For example, the use of face masks and also the reduced mixing of year groups in schools. We only have the country level NPI policies and it's very broad. For example, for school reopening, we only know if the countries allow school reopening or not, and we do not have further information on that. So hopefully that can answer your question.
So thanks for the answer, Leo. I don't see any other questions being posted. So once again, thank you for the excellent talk, and we move on to the next part of the conference today. Next slide, please. So now we've got something quite different from what we had on the previous days of the Uncover conference. We have today our Uncover project manager, Emily McSwiggan, talking to Dr. Nicola Brink, who is the Director of Public Health in Guernsey. And Nicola is the senior most advisor for health matters to the government in Guernsey, and she advises senior politicians and committees on the island's response to the pandemic. And not only is she responsible for advising the government, she's then responsible for delivering on the policies that the government has decided on. So this is going to be quite an interesting talk where you're going to hear from someone who is both in an advisory capacity as well as someone who is implementing that and overseeing that implementation. Over to you, Emily.
Hi, everyone. Can you hear me all right? I'm going to hope that you can, unless someone lets me know otherwise. My name is Emily McSwiggan, and I've been involved with the Uncover team from the start, part researcher and part project manager. But with another hat on, I've been a politician in Guernsey's small independent government for the last 4 years, including throughout the start of the pandemic. And I'm joined by Dr. Nikki Brink, who's going to introduce herself properly in a moment. Nikki is Guernsey's Director of Public Health, which makes her the most senior public health advisor to the government here. So safe to say she was the single most important person in guiding our island's response to the pandemic. And what we want to do together is to give you a bit of insight into the reality of making high-stakes decisions in a crisis and the challenges of evidence-based policymaking in a context of political and public pressure and fear and huge uncertainty. So, first of all, Dr. Brink, can you tell us a bit about who you are, your background, and your role in helping Guernsey to manage the pandemic?
So first of all, thank you so much for having me here today. It's a huge honor and privilege to be here and discuss some of our experiences with you. I was actually born in South Africa, studied medicine in South Africa, and specialized in virology there, so a branch of pathology. Came over and worked at University College Hospital in London as a consultant and senior lecturer. So I split my time between academic research, teaching medical students, but always retained my clinical role as well. And I came to Guernsey in 2003 and initially worked on the clinical HIV and hepatitis service, and then moved into public health and became Director of Public Health in 2018. And essentially in the pandemic, as Emily said, it's a combination of a strategic role and looking at policy, looking at the evidence to underpin our local policy making, but also being responsible for operational delivery as well.
Thank you, Nikki. So, of course, Guernsey has had to make the same kind of extraordinary decisions as other countries have over the last few months to help manage the impact of COVID-19. But what I really want to draw out is the process of decision-making and how public health evidence plays a role in that. So I think it would be good to start from the beginning and to ask, When did you see the pandemic coming, and what did you do to make sure that you were prepared as a public health team, and also that key decision makers in the government were prepared for what might be coming?
So thank you for that. So from my perspective, communication and preparation is absolutely key. And in fact, we started preparing before the pandemic. And in November 2019, we ran a pandemic tabletop exercise. And at that stage, we were having a lot of pressure with regard to Brexit. And I received an email asking us to cancel our pandemic flu tabletop exercise. And that did not receive a favourable response from me. Those who know me know that I'm fairly outspoken. And I said, nope, it was not acceptable to cancel our tabletop exercise. It was not a case of if, it was a case of when. And it could be an influenza virus, but our next pandemic could be caused by a novel respiratory virus. Little did I know 2 months later we would be looking at a similar situation. So from our perspective, in January of this year, we took a close look at the emerging situation in Wuhan City in Hubei province, and we decided that the virus did have pandemic potential and we should prepare as such. So we briefed our health committee accordingly, saying that although a pandemic hadn't been declared, we felt that this had pandemic potential. And from our perspective, being a small jurisdiction with limited resilience, we have one hospital, one emergency department, one intensive care, that being prepared was absolutely key for us. So we set up a scientific and technical advisory cell to start looking at the data. We briefed our senior teams from a public health perspective, both in the civil service, health and social care, as well as a political level. And we decided to prepare a strategy and look at how we would manage a potential pandemic and to communicate this early. So by way of an example, very early, we said we were going to go for a community test, trace and track system. And we prepared accordingly and started training up contact tracers at the end of January and into February.
Thank you, Nikki. And of course, as a politician, I was part of the island's health committee, which was the body responsible ultimately for many of the decisions that we made about how we handled lockdown and other restrictions early on in the pandemic. But you were the person who has had to stand in front of us and in front of various other political committees throughout this period and recommend the best way forward through some really difficult decisions. And how important was it then for you to be confident that your recommendations were based on evidence? And also, I suppose, how did you deal with political pushback or challenge on those recommendations?
So I think basing recommendations on evidence is everything. But the 2 points here that I think are important. The first is that we weren't sure of what the evidence was. This was an emerging situation with a novel virus, and we needed to be very cognizant of that. The second point that we wanted to make very clearly was that it needed to be local evidence. So the World Health Organization said at the very beginning we need to plan a response that is appropriate for our jurisdiction. And we really agreed with that. And if anything, if the pandemic has taught us anything, it's that a one-size-fits-all approach cannot be adopted. You need to analyze the data and make sure it's fit for purpose for your community. I think with regard to challenge is I regard that as an advantage. I think challenge and pushback really makes you consider your decision making and make sure it's appropriate. And sometimes when I got challenged, I would look at it and say, well, okay, that's a fair challenge. Let me go back and consider this in greater detail. And I think all of that is positive. And I think one of the highlights for me was how in Guernsey we worked as a single organization. So public health, health and social care, the wider civil service and our politicians became one team. And information flowed freely between the teams, and we looked to support and challenge each other, but in a constructive way.
Yeah, I think in our opening talk today, Aziz talked about the importance of trust and trusting relationships between decision makers and the people who are providing evidence. And certainly in my experience and what you've just described, Nikki, that's how it felt, and that helped us really shape our response. And there were some very difficult decisions to be made, and one of those, one of the most significant ones early on was the moment when we moved the island into lockdown. Can you tell us a bit about the circumstances surrounding that, the specific local factors that led to that decision being made?
So thank you. And it was an extremely difficult decision. And for those of you who are not aware of our island's history, is we were occupied by the Germans in the Second World War. So deprivation of liberty has an extremely poignant message for all of our islanders. And so from our perspective, it was really important to consider what we did and why we went into lockdown. Now, we went into lockdown on the 25th of March, and in the weeks before the 25th of March, some really important things were going on within our community. The first is that England changed their testing strategy to a hospital-based testing strategy, and we were having problems getting our samples processed. At this stage, we were sending our samples off island, and they were being tested in various labs around England. So from our perspective, that withdrawal of community-based testing, and on top of that, because of the testing issues that were being seen in England, is a cap was put on the number of tests that we could do per day. Now, our strategy was a community test, track and trace. And so being asked to move to a hospital-based policy when we only had 2 patients as inpatients at that stage was entirely inappropriate for us. And that then had triggered, at the end of February, beginning of March, us to look at investing in our own testing capacity. But on the 25th of March, we didn't have that testing capacity. And what happened 2 days prior to that, we had our identification of our first case of unexplained community seeding. Now, prior to that, we had had some 100 cases on Ireland, but all of those we had been able to link clearly to travel, so imported infections into the island, or alternatively to contacts of travellers. And on the 23rd of March, the first case popped up that we couldn't explain. We couldn't find a thread of transmission. The second thing was our testing capacity and the lack of availability of local testing. So there was doubts about the number of tests we could do, about the long-term availability, whether we were going to be trying to run a local program with another national strategy that wasn't commensurate with our local program. And for that reason, we really felt that we had to pause and go into lockdown until we had an on-island testing capability. The other thing that was happening is our swab-to-test time was about 4 to 5 days. Our swab-to-test result time was about 4 to 5 days. We aim to start contact tracing within an hour of getting a positive result, and on top of that, we aim to have our tests through in 12 hours. So that really agile approach to contact tracing was important. And the third thing that was worrying us was the fact that there were reports in our community that something was going on. There weren't typical symptoms, and so we couldn't access testing in the UK because they weren't fitting the fever or cough or shortness of breath within appropriate travel history. But we knew something was bubbling in our community and indeed in one of our care homes. The presentation was atypical, but we were really suspicious that we were looking at something. So the 3 things, the community seeding, the absence of on-island testing, together with something going on in our community, made us believe that we should go into lockdown. And just to say, our lockdown was enormously effective because 10 days after going into lockdown, we had a complete flattening of our curve of infection.
So some really high-stakes decisions that had to be made there, Nikki. And a question that's come in from the audience, you mentioned earlier about the pandemic pre-planning exercise. Did you find that there were tangible benefits to having gone through that so soon before having to make this kind of decision in reality? Did that play out in our decision-making?
Without a doubt, it was important because we thought of our lines of communication. So we identified potential areas that were lacking. For example, we felt that our comms and media strategy needed to be enhanced. And in fact, in my view, the comms and media with regard to our current management of the pandemic has been a strength. And I can say that because it's not my direct department, but they have been incredibly effective in their management. So we were able to look at issues like that. So we were also able to look and plan, for example, for excess deaths should they occur. So we wouldn't be doing that on the hoof. But more importantly, it got us all in the same room where we got to know each other, and having those pre-existing relationships and those good communication was fundamental. So I think it was of paramount importance. And I was very glad that I insisted that it went forward.
We all are, I think, and of course we're really lucky to be in a place where for the past few months we've been thinking about lifting lockdown and easing some of the restrictions on our community. But those kind of decisions are not straightforward. It's really the place where public health evidence meets sort of ethical and value judgments. And I wonder if you could talk us through some of those considerations, perhaps especially relating to children and their education and how we manage that.
So we came out of lockdown in an incremental fashion, and we used evidence and the cycle of viral replications to determine each step. So our last case of community transmission of SARS-CoV-2 occurred on the 5th of April in our community. Since then, we've had no community transmission within the bailiwick of Guernsey. So that's really important. But as we were coming out of lockdown, we were also considering the ethical and moral judgments with regard to what restrictions you release, what restrictions you keep. And we felt it was important that we valued getting children back to school. So before we came out of full lockdown at the end of June, is on the 8th of June, all of our children went back to school with no social distancing and with no restrictions on them whatsoever. And this was extremely positive. But in preparation for this, we engaged with the unions. And again, it's communication, sharing our data. We've always had this attitude that the data does not belong to public health, it belongs to our community, and we should share it and make it open and transparent. And yes, I had a lot of armchair epidemiologists offering me lots of advice. However, some of that advice was really interesting. But going back to the children, we engaged with the unions, we explained the situation we're in, we shared all the data, we asked them to raise any queries, and in fact the unions fully supported our children going back to school with no restrictions. And again, as we moved incrementally, we looked at what restrictions we could release until on the 20th of June we came out of lockdown completely. So we now live in an island with no internal restrictions. What we do still have is our border restrictions. So we have self-isolation on entry into the bailiwick combined with a testing program.
Super. And can we talk a little bit then about the importance of putting evidence in context when it came to all this decision making? So you and your team will have found all sorts of research out there, but one of the key challenges we know was identifying what's really relevant to Guernsey. So with the benefits that we have as a small community and with the political independence that we have, but also the constraints of being a small island. So how have we sort of sorted through what is relevant and what's not so relevant, and how did you then make sure that your recommendations were evidence-based, but also tailored to the specifics of our local situation?
So we used a combination of international, national evidence, but also what was relevant for us locally, as you said, Emily. And I think it's important. So, for example, our first case in Guernsey occurred on the 9th of March. And that case came from an area that wasn't specified as an area of concern by Public Health England. However, we felt just looking at what was going on in that area that it was an area of concern for us. There were multiple small clusters in the community. To us, it looked like there was community seeding them. So we decided to include that in our classification of areas of concern. And in fact, that enabled us to diagnose our first case. The second thing is interrogating and analyzing our local clinical data. And after we saw our first 100 cases, we looked at the data, and about 50% of people had loss of smell or taste. And so we decided to include that in our clinical diagnosis, and we did that about 3 or 4 weeks before it became part of the UK clinical diagnosis. And again, that was based on looking at the local evidence and saying, this is of concern to us. The other thing is by this time we'd also had, we had two outbreaks in our care homes, and that accounted for all the deaths that we had on Ireland. So we had 13 definite deaths and 3 presumptive deaths. And so we were very cognizant of looking at what the symptoms were in older people. And what became really apparent to us is that the symptoms in older people can be entirely atypical. And what we saw is stool slightly loose, not diarrhea, but just not themselves, worsening of dementia, so really subtle symptoms. And what we were seeing in our care homes at coughing, in fact, was a very late and a significant fever. It tended to occur late. So for that reason, as when we renewed our case definition towards the beginning of April, we included atypical presentations in older people as part of our testing. And at that time, we had then scaled up to be able to do on-island testing. So by the end of March, we could test 160 to 200 samples a day. Now that may not sound a lot to you, but on a proportionality basis, that was the equivalent of 200,000 per day in the UK. And that was important to us. That was at the time that the UK was aiming for 100,000. We now are scaling up further, and by the second week of October, we'll be able to do 2,000 to 2,500 tests a day on island, and that then will be the equivalent to 2 to 2.5 million a day in the UK. So developing that on island capacity, using that evidence to define our decision making is really important. And I think that's also important as we move into possibly a difficult winter, that we have this testing capacity to look at how we can manage our situation safely here.
So thank you, Nikki. Just conscious of time, I think I'm going to try and fit in two more questions if we can manage it. So one of them, just linking closely to the work that we've done as Uncover. Obviously, as Uncover, we were pleased to be able to provide you and the team in Guernsey with some of the preliminary evidence on how other countries around the world were approaching the challenge of defining elimination, especially other, admittedly larger island nations like Australia and New Zealand. And of course, we know that COVID is likely to be with us for a long time yet, and really stamping it out would require a global effort. But can you update us on your thinking about how we approach the definition of elimination locally, and why those definitions are useful?
So I think the definition of elimination, you can either look at the number of new cases and a 28-day gap after double the maximum incubation period, or you could look at virological resolution and 28 days after that. We ended up looking at virological resolution of the community cases and then timing 28 days after that. Now, I think elimination was not a strategic goal for us, but elimination and the definition of elimination was important because it supported our decision making. So when we started removing all of our internal NPRs, our children going back to school, having the evidence that we had no evidence of viral transmission, active COVID-19 in our community was central to the decision-making process with regard to the lifting of NPRs. So it wasn't so much a strategic goal, but it was to support our lifting of NPRs that it was critical. And we're very grateful for the work that you helped us with.
Thank you, Nikki. And finally, I wonder if you might be up for giving us a little career advice, because one of the things that Uncover has been is a great opportunity for MPH students and other students at Edinburgh and others with relevant knowledge to work together with senior academics to produce really sort of useful topical answers to policy questions on COVID-19. And the conference today has been about allowing those who got involved to showcase that work, because the academic year is coming to an end. People are starting to think about moving on, possibly getting jobs in the world of public health. And I wonder if you might quickly talk us through your team and the kinds of different work that you do here and the different skills that people bring to the table, just to give us a bit of a window into the incredible variety of potential public health opportunities there are out here.
So first of all, I would thoroughly recommend a career in public health. I think it's one of the most important fields in medicine. I would say that, but you have the ability to affect population health and well-being as a whole. Our team is extremely diverse. It has doctors, it has nurses, it has our public health practitioners who come from diverse areas. We've got an actuary who's our lead contact tracer. We've got someone with a PhD in molecular microbiology who's involved in all of our analytics, so helps us with the definition of country prevalences and so on. So I think what's really important, it's diverse, it's exciting, and after COVID's over, working on programs like we've got a program, Elimination of Cervical Cancer. We're on track to eliminate hepatitis C from the island. We're looking at teenage pregnancies, and our rates are now amongst the best in Europe. So it's pushing all of these goals forward. So it won't end with COVID. So come and join us.
Thank you ever so much, Nikki, and thanks everyone for your patience in listening to us. I hope that was interesting. I'm going to hand back over now to Harish to close, I think. Thank you.
Yeah. Thank you, Emily and Nikki, for the wonderful conversation. Lots of insights there on the role of local governments in decision making and how small is more agile. So next slide. So we're now to the end of this Uncover conference. It's been wonderful to have you all with us over the last 3 days. The recordings are available on the Uncover website. So at the bottom of this slide, you're seeing the link to that. And today's presentation and the talk, everything the recording is going to be available later and on the website as well. So thank you everyone for making the time, and hope you all have a good day. Bye.